My name is Dr. Jack Lambert, and I'm an infectious disease specialist in Dublin, Ireland, where I've managed over the years a number of patients with tick-borne infections. And one of the critical components, I think, of moving forward to better understand tick-borne infections is to kind of solidify the relationship between, the One Health initiative between the medical and the veterinary doctors who are managing these patients and running into the same challenges. And I think the additional kind of important strategy that we have to do is to look at doctors who are managing patients with chronic Lyme infections and find a way to be able to collect that data and to be able to kind of put it into the scientific community to advance the science of tick-borne infections and our understanding of the importance of treatment and the fact that Lyme is not easy to diagnose, not easy to treat. And there's many other infections besides Lyme disease that we need to think about. The title of my presentation is International Collaboration and Data Sharing from the Clinical Trenches. And I think as people who manage Lyme patients and people who are affected with Lyme is that we've minimized the complexity of tick-borne infections. And there's lots of challenges within this. It's not a simple disease. It's a complex disease, and it's not just the infection, but it's the immune responses that occur as part of this infection. It's the fact that there's ongoing damage to the host tissues. And finally, there's also clear evidence that the simple guidelines of 2 weeks of antibiotics don't cure all people with Lyme disease. And besides Lyme, Borrelia, there's many other bacteria that are spread by tick-borne infections, and most of testing for most of these infections are not available. We've been able to map the ticks that are common around the world. This is a slide of the European demographics. There's a number of different ticks, and these ticks not only bite humans, but they also bite animals, both domestic and wildlife. And this is just a slide that kind of demonstrates, some of the studies that have been done in the UK, looking at the prevalence of ticks within different regions. You'll see that there are hotspots within the United Kingdom, spots being Scotland, hotspots being southwest England, and also parts of eastern England. The ticks are everywhere, throughout the European Union, throughout UK, throughout North America, worldwide. And it's really important that we have the ability to map the ticks, map the prevalence of infections in animals, and also the prevalence of infections in humans. We did a tick study in Ireland because I got tired of listening to people saying there are no ticks in Ireland, the ticks don't carry infections. And we actually tested a number of different sites, 6 different sites in Ireland, harvested the ticks and performed PCRs through a professor in Milford, Connecticut, Professor Lee, and we're able to identify that ticks, yes, indeed, ticks in Ireland are carrying Borrelia, not just Borrelia burgdorferi, but other strains, including Borrelia miyamotoi. So the range of tick, infestation with Borrelia range from 2% to as high as 12%. And these studies have not just been done by medical doctors, but there are colleagues at UCD Veterinary School led by Annetta Zintel et al. They harvested ticks from that were being carried on a number of the animals, and they identified a number of different infections in the Irish ticks. And these infections include Borrelia, which we knew of, but also Babesia and Anaplasma rickettsia. So if these ticks are biting animals within Ireland, they're also biting humans. And humans are likely being infected, not just with Borrelia, but other infections as well. So this is kind of the life cycle of Lyme disease ticks. And the challenge is many people, I think, are missing the diagnosis of Lyme disease. Only 15 to 50% of people diagnosed with Lyme recall having been bitten by a tick. The rash is only seen in 40 to 60%. And it's easily to miss that you've been bitten by a tick. They're small in their larval and nymph stages, and they may not be present. If you get bitten behind the ear, if you get bitten in the scalp, if you get bitten behind the legs, you would identify these infections. And then the next challenge is that the diagnosis is difficult. The antibody test is the only commercially available test for humans. And we did a study actually in Ireland comparing standard Irish, UK, at least, ELISA Western blot, and compared it to the quote unquote non-traditional testing, the ELISpot assays. So we did a range of testing, and these slides just actually summarize that when you compared ELISpot to the C6 ELISA, you missed 62% of the cases. The ELISpot to Western blot missed 82%. And when you did the ELISpot with a two-tier test that is recommended for diagnosed in humans, you missed up to 83%. So we're missing lots of cases of Lyme disease. And this also summarizes the different testing that have been done. That is the standard, gold standard according to human diagnostics, ELISA, C6, Western blot, two-tier. We're missing almost 50% of cases of Lyme disease in humans, and these are documented positive Lyme cases. So there's limitations in testing. Antibodies don't actually affect huge numbers of Lyme cases. Testing is not done as a rule for other tick-borne pathogens. And interestingly, our veterinary colleagues have PCR tests available, antigen-specific tests. But these tests are not available for human medicine. This is a study that was done in the UK, and they actually, to summarize this slide, is that they did an analysis, and the number of cases recorded have increased from 60 to 595 to a predicted 7,758 cases dating back to 2012. But if you look at even recent reports from the UK in terms of laboratory diagnosis of Lyme disease, they only report in the range of 2,000. So we're missing many cases because testing is not done. This is a slide kind of summarizing the underdetection of Lyme disease in Canada, a study done by Pat Lloyd et al., and it's referenced here. And they used the Providence in New Brunswick, Canada as a model. They included human data on Lyme prevalence in the USA states and counties bordering Canada. They used published national Lyme seroprevalence data, and they used high-density tick and canine surveillance data, and they estimated the underestimation of Lyme cases in this particular province was between 12-fold to 58-fold. So we're missing many cases of Lyme disease. This, one of the ways that we record Lyme infection is ICD codes, and we now have ICD-11 codes, which have just been recently kind of approved. So we will have the ability in the future to better recognize different conditions associated with Lyme disease in humans. Interestingly, congenital Lyme borreliosis, IC1G2, was eliminated from this. So we will never be able to kind of measure the true extent of Lyme disease in pregnancy because we have no coding for this disease. So linking ticks, human and veterinary data and prevalence, incidence, and tick-borne infections. Enhanced ICD-11 codes will expand our ability to catalog Lyme infections only if mandatory reporting of all confirmed or suspected cases are made, reporting all cases. In Ireland, only cases of neuroborreliosis where patients are admitted to a lumbar puncture performed and specific abnormalities are found in their CSF are reported nationally. The Irish Surveillance Centre says data from blood donors in high prevalence areas shows 1 in 5 are antibody positive. But then they turn around and say it's estimated, but there's no good data, that 200 patients have positive blood tests for Lyme annually. But I've looked at other unpublished calculations by some of my colleagues, including Healy et al., who've estimated there's probably 2,500 annually. Ireland has a population of 5+ million people, and we're only diagnosing 2 cases a year, according to the criteria used for reporting in the Irish population. So the challenge now, moving forward as a clinician, is there is this condition called PTLDS, post-treatment Lyme disease syndrome, which has been defined by the Infectious Disease Society of Ireland, that once people have received 2 weeks of antibiotics, they're no longer infectious. And they state there's no convincing biological evidence for the existence of symptomatic chronic B-burgdorferi infection among patients after receipt of recommended treatment regimes for Lyme disease. The other contrasting group who manage Lyme disease is ILADS, and they have stated that there is evidence of persistence of B-burgdorferi in animal and human models, and these are just a number of publications that show that there is persistent infection, both in humans and in animals following treatment for Lyme disease, kind of begging the question, shouldn't we be treating patients, not treating guidelines, and treating patients for longer periods of time? I treat patients based on their symptoms, not necessarily based on the guidelines. And we did an audit of one of the first 100 patients that we presented who had chronic fatigue as part of their story. And they really had a convincing story that they had Lyme disease, either a tick bite, clinical symptoms, or laboratory evidence of Lyme disease. And we actually put patients on combination therapy, not just treating Lyme disease, but also co-infections. And we have treatment results available in 70% of the patients who returned. 30% of the patients didn't return for treatment. But 69% of people responded to treatment based on clinical questionnaires. They clinically improved. 31% did not improve, which really kind of, begs the question that isn't it good to treat people for longer if there's persistent infection? And how do we better record this? How do we document this? How do we put the data together to support this? What about these 69% infection treatment with antibiotics? And then this infection is an autoimmune inflammatory disease. Many of these patients were also given monoclonal Infectious, and then lots of these patients were given treatment supplement. The challenge is getting these publications published in the medical literature, getting this data analyzed and published in the medical literature. Recently, my colleagues and I submitted, a review of a case of an individual who'd been sick for a couple of years with Lyme, following classic tick-borne infection, bullseye rash, getting sick following it, getting better with 2 weeks of antibiotics, getting worse following discontinuation of the antibiotics. And we tried to publish his case, which was the case of getting treated for a longer course, 4 months of treatment, covering not just Lyme. He was positive for anaplasma as well. We received very difficult resistance from the reviewers, who basically said, you can't publish this because you never saw the tick bite yourself. It was not good enough to have the report of the GP who recorded the tick, the rash following the tick bite, the ECM rash. So we had to change our publication to say potential persistent Borrelia infection to get it over the line and into the scientific literature as a publication. Recently, in partnership with Oxford, we submitted a grant to NIHR Health Technology in the UK, which is one of the research bodies. And we actually tried to get published, tried to get funding on to analyze the research samples that we collected before and after treatment on patients with chronic Lyme co-infections. We'd actually collected all the data on their clinical symptoms, and we'd all of the clinical laboratory tests done. We'd planned exploratory studies using metagenomic sequencing, L-form cultures, Raman microscopy, and assays of mitochondrial functioning dynamics. The proposal was rejected with the following summary. The group are not convinced the proposal presented sufficient evidence to demonstrate efficacy of the proposed interventions to move and evaluate to an evaluation of effectiveness. So the challenge for all clinicians managing patients with Lyme, chronic Lyme, who are taking care of these patients and seeing them improve on treatment is to get the appropriate funding. So, tick-borne infections, the spectrum of infection, disease manifestations, and optimal therapies in animal and human populations. One Health, this is the strategy we should kind of push towards. At the present time, we're not linked up as we should be. We need better surveillance data on tick-borne infestations of Lyme and co-infections in wild and domestic animals and in humans. This is necessary to move forward. We need better diagnostics. The antibody tests are imperfect. We need antigen-based tests. Interestingly, the vets some of these infections. The private sector are treating these patients. How do we collect data from the private sector? Because the private sector needs to be able to conduct research. There's been recent private research funding provided that has showed persistence of Lyme despite the currently approved treatments. Not every person treated with 2 or 3 weeks of doxycycline is cured of the Lyme infection. We need better studies, but we only will get better studies when public research institutions acknowledge the existence of chronic infections, and they have to accept these studies to better understand this condition. So in summary, it's complicated, and we have a long way ahead of us to better put together the data to convince people of the persistent infection, and also to get this data into published publications in the scientific domain. Thank you.